Yeah. So, a very good morning, friends. Uh, it is the first session on day one, starting at 8 o'clock in the morning. We have a fantastic faculty for this course, Recent Concepts Optimizing IOL Power Calculations, which have been going on for last couple of years. And we are really very happy and very privileged to have Dr. Douglas Coke amongst us. I mean, there will be a formal introduction before he starts his talk. And then we also have a started team, Dr. Nirupama. She is an additional professor at Jipmer Pondicherry. Dr. Ramesh Durarajan, one of the most brilliant ophthalmologists I have encountered so far in my journey as an ophthalmologist. And then we have Suven, a brilliant innovator. He has given us the BX design, and he also takes a lot of interest in this particular field. And then we have Dr. Anand Parthasarathi, and Anand, again, is a very brilliant cornea and cataract surgeon in Chennai, and a very intelligent person. And with these words, this is actually the course for the program today. Dr. Daug has a keynote address, current IOL calculations, current state of the art, but I think we'll wait for some time till we have more number of people filling in the room. And then we have the subsequent talks, Dr. Satyamurthy, contemporary tools, strategies to optimize toric outcomes. So Satyamurthy, if you can get ready, it will be great. And then it will be followed by Dr. Ramesh, incorporating cutting edge technology in IOL calculation. Anand Parthasarathi, recent developments in post-refractive surgery situations. My talk is IOL power updates in common posterior segment pathologies. Suven will be talking on the extremes, the long and short eyes. And then finally, the session will be rounded up by Dr. Nirupama on a talk on IOL calculation, pearls to take home. So with this, word of introduction, I request Dr. Satyamurthy. Satyamurthy, are you ready with your presentation? So we are indeed privileged, until Satyamurthy comes on the screen. Every other JCRS issue or any other peer-reviewed journal that I come across, there are articles on IOL power calculations. So this particular area, JCRS, January had two articles on IOL power calculation. February had 3, March had I think six or seven, and April had already 3 or 4. So it is such a happening field. And it is all because we have such stalwarts, such gurus of IOL power calculations. Dr. Dow Koch, we have, every time we do an IOL power calculation in our country, we remember your contributions that has made the science as what it is today. And so thank you so much. And we're really privileged to have Dr. Dow here for this meeting. So, Satyamurthy? Yeah. So then Ramesh, you are ready? So if Satya has some issues with his slides coming up, Ramesh, the next speaker is Dr. Ramesh Durarajan, incorporating cutting edge technology in IOL calculations. Maybe you can use that laptop, no?
I did the speaker check-in, but it's not coming up here. Okay, should we refresh this? Can you help me? Because we did the check-in about half an hour back.
So Satyamurthy, this thing is ready, or he doesn't come here? Yeah. Okay.
No, we did the loading in the. Hello. It's here.
Ramesh, I think it would be better if you do it from your pen drive.
AIOS2025. Yeah. First one, yes, please. Yes. You can just go to screen show. Thank you. Thanks, Arup. So my talk is on incorporating cutting-edge technology into IOL power calculation. In a WhatsApp group, you always end up seeing these kind of messages. I performed an uneventful phaco with a multifocal lens 20 days ago. Unfortunately, the patient has a residual error of 0.75 or 1 diopter, and the patient is not happy. Now, what is the best option? So we see these messages, and it troubles all of us. In a 2023 CRST interview, Professor Doug Koch said that a 90% accuracy is probably our ceiling, and patients must be informed that they have a 1 in 10 chance of having a residual refractive error. The technology that we use can be high-tech, but should be appropriate if you're working in a small rural center, or whether we are working in a large corporate hospital with a lot of funding. We can choose to have high-tech options that is low cost or which is expensive. The first step to get good power outcomes is to optimize the cornea and the tear film, and we have some low-cost options like the eyelid size. This particular instrument is actually a warmer which heats up the lid, and it's got safety controls inside, and it was designed by an AIOS alumni. We also had to do lid scrubs and use any preservative-free artificial tears 4 times a day. We also have very high-tech options for this, like upgrading the lid margins, like intensive pulse therapy, like thermal pulsations. So we have high-tech options to optimize the corneal surface. All optical biometers will give accurate axial length values. But the SSOCT-based devices are better in acquiring data from eyes with wide cataracts and hypermature cataracts. In this 2023 article, which compared 4 different optical biometers, the B-scan, the AcuScan, and the Argos were able to image all the eyes with dense cataracts. Next came the IOL Master and the Anterion, and Pentacam did poorly. Only about 60% of the series of eyes could acquire a proper axial length. In the days when we did manual keratometry, when we had a cornea like this, we know that we had to ask him to blink or we have to optimize the cornea. But the older versions of optical biometers and the older versions of IOL Master cannot differentiate a pristine cornea and a cornea with a poor tear film. But the newer versions can. Can you make out the difference between the picture on the right and the picture on the left? If you see one, you have split circles and you have distorted circles. So when the operator sees these kind of dots on the review panel, he has to retake this particular one while you can use the data from the right eye. The OCT also gives you an OCT image of the lens. We all deal with posterior polar cataracts, and we are worried that we're going to have a problem intraoperatively. But when you see a beautiful posterior capsule like the second and the third, we don't have to discuss the risk of PCR with these patients because they'll have a routine intraoperative procedure. This is an IOL Master lens picture from a with a posterior polar cataract where you can see a nice bulge of the posterior capsule. So this patient probably will have to have the discussion about increased risk during surgery. This patient developed a PCR. He came with a white cataract. He gave history of having multiple anti-VEGF injections. You can see a beautiful tear in the posterior capsule. So preoperatively, through this white cataract, the IOL Master 700 could pick up a torn posterior capsule. In 2024 July, there's a compilation of IOL power calculation formula and when to utilize them in iWiki, and it made our work much easier. So for all spherical IOL power calculations, please use Barrett Universal 2 or a Kane formula. Among the various toric calculators, Kane toric and Barrett toric give you the best results. In cornea with prior refractive surgery, please choose Barrett's TrueK formula. And if you have access to the Alcon Varion or Zeiss Callisto, you can do markerless overlay to improve the location and shape of your rexus, and you can also do axis marking with that. Using a topography is also important because it will help you to pick up a keratoconus like this. Otherwise, you will end up treating the central part with a 2.38 cylinder and miss out the much larger a cylinder that shows up, a 6-cylinder when the pupil dilates. So photopic and mesopic powers will differ in eyes with irregular corneas. In future, we believe that wearable simulators will give a patient an experience of vision with various IOLs before we implant them. So this is a Vivo Optica from B-Vision. And in this, the patient data is captured on top left, and then the computer works on it. And using adaptive optics, you have a wearable heads-up device. It gives you the simulation of what you will see with an EDOF lens or with a bifocal lens or a trifocal lens or with monovision. So you can give an experience of how the patient is going to see after surgery by using these advanced machines. But we had to think about this: expensive equipment, expensive maintenance, expensive replacement parts. This particular doctor purchased an IOL Master 5 years ago, and he had to change the motherboard last year, so he ended up paying an extra 6 lakhs, and currently he's paying an AMC of 2 lakhs. So over a 10-year period, these equipment will cost you 60 lakhs plus, and over your lifetime, you're going to spend more than 1 crore rupees on just any one of this advanced equipment. Our revenue stream is uncertain with our insurance payouts decreasing. So although we want the best outcomes for our patients, we had to make sure we don't get diabetes, hypertension, or ischemic heart disease. We should not pay a price for the better outcomes that we aim for our patients. So incorporating high-tech solutions can be painless if you choose low-cost solutions like using an online Barrett's or Kane formula, which is applicable to all. The high-cost solutions should be used only when they are appropriate. Thank you.
This has to be switched on, yeah. So thanks a lot, Ramesh, for a wonderful talk. As Satyamurthy gets ready with his presentation, contemporary tools or strategies to optimize toric outcomes. Is there a question for Ramesh? So I would like to ask Dr. Ramesh and get an opinion from Dr. Kau that, you know, in Vienna, a study is ongoing where they have a new source OCT-based device, which actually costs less than $200, and yet the marketing price will be less than $2,000. I think which is supposed to be, it is even going to be lesser than an A-scan machine. So, Doug, you have any idea about because it came in the American Journal in January 2025 issue. So that was very impressive.
I was actually one of the reviewers for that paper, and I think it's a very interesting technology, and it looks very promising. It showed almost equivalent penetration and equal accuracy to the more sophisticated devices. So I think this is something we're going to see, and it would be fantastic to have a much less expensive device. Of course, there are a whole lot of other things you have to do in such a device, like get good corneal readings and do all the other parts, but I think it's very promising.
Thanks a lot, Doc, for the comments. And next, Satya.
Good morning. At the outset, I'd like to thank Dr. Arup for giving me the opportunity to participate in this CME, in this instruction course. Toric IOL is the best way of correcting corneal astigmatism, even though there are other ways of doing it. But whenever we have to implant a lens, probably the Toric IOL is the best, especially when the patient comes with cataract, and this is highly satisfying. All we have to do is to develop the proper concept to correct the corneal astigmatism. In my practice, I take 1 diopter as the cutoff point. Anything more than 1 diopter, I go ahead with the thing. But there are a lot of people who are doing with minus 0.75 diopters also. IOL power calculation, which has already been dealt nicely in the first talk, is of paramount importance because patient comes to us for visual recovery, and the visual recovery mainly depends on this. Whatever method works well in our hand for regular cataract surgery is okay. A lot of newer IOL power calculations formulae are available, but as Dr. Ramesh said, the Barrett's toric IOL power calculation is the best. Since we are going to mainly focus on corneal astigmatism, keratometry plays a very important role, even though we can measure central keratometry value in many ways. But what I feel is whatever way of measuring keratometry for corneal power for IOL power calculation in our routine practice is okay. I prefer keratometry from IOL Master 700, even though I do not have any financial interest in this, but I make sure that it correlates well with the other keratometry values from the autorefractometer and topography. And then already has been dealt with this particular topic. We will have to stabilize the ocular surface. We can get on ocular surface analyzer. In case it is axis deficiency, it has to be rectified. In case if it is meibomian gland dysfunction, then probably one can go ahead with the various ways of treating it, including IPL or maybe Thermiflow. I feel topography is a must because now topography is available with everybody. It's a must for various reasons. One is to know if it correlates with other K values and axis determination, and to see if cornea is regular, set to rule out keratoconus or pellucid marginal degeneration, to see if corneal status is regularized following any of the corneal surgeries that including pterygium surgery. We will see an example later. And then to know if patient has already undergone laser vision correction earlier and doesn't give the history. This is one example where a person was counseled properly and then he underwent toric IOL implantation, but regular lens implantation. To our surprise, patient later on was not happy, and then when we did topography, it was an aborted case of keratoconus. So probably if I had done this earlier, I could have easily counseled the patient in a better way. That's why topography is important. Second thing is this particular patient with the pterygium and cataract underwent pterygium, and then after 1 month, as the usual practice, underwent a toric multifocal IOL implantation. But to my surprise, the astigmatism went on increasing up to almost 16 weeks before it became stable. So the model here is we should always wait for topographic stability in these cases. It is not just not to go by the time. And then Baylis nomogram, of course, Dr. Douglas Cock is here, and he and his team, they have given this particular thing where the topography can give us posterior corneal astigmatism. In case if it is anterior, with the rule astigmatism, jump up by 0.7 diopters. In case if it is against the rule astigmatism, jump down by 0.7 diopters. Next important thing is reference marking. There are various ways. Manually, we can do it in the patient, the sitting position. Best way is to do on a slit lamp. There are so many markerless things available now in the form of Varian or Callisto. And axis marking can also be done with the Mendes marker, which is normally being done. Any rotation more than 10 degrees becomes clinically significant and requires the rotation if patient complains. As you see here, the reference marks are way ahead, they do not match with the 0 and 180 degree. I think so this is with the eye trace. So one is above, one is below. So using Zaldivar's caliper software that is available, incorporated in this, tells us as to how much, keeping the same reference markers, we can move the, we can rotate the lens so that we get perfect thing. Optivia refractive analysis, that is ORA system, the intraoperative barometer enhances the toric IOL surgery by providing real-time measurements and calculations to optimize IOL power and axis placement, leading to improved refractive outcomes. ORA tells us how much to rotate intraoperatively to get proper refractive correction. But all said and done, this also has got a lot of limitations and drawbacks, and it may not be affordable to every cataract surgeon. Then when it comes to the surgery, to give proper outcomes, one is the incision site. Even though we plan it at 0 degrees, sometimes it may not be possible because of the rotation, the torsional rotation of the eye. And then in case if surgeon is not comfortable in that particular position, it's always better to choose an area where he is comfortable, probably a little on either side of the 0 degrees. Then rexis should be central, circular, and at 5 to 5.5 millimeters to avoid the decentration of the lens in future, because the fibrosis can be influenced. And then in case if we use viscoelastic substance for implanting the lens, maybe we can stop short about 10 to 20 degrees and then remove the viscoelastic, especially under the IOL, so that the lens doesn't rotate, and then make the final correction. Best thing would be to do a under BSS implantation. Then the third thing is to prevent extra, overheating the antechamber because a layer of fluid can go underneath the IOL and can destabilize. And then post-op management, first 1 hour is where the maximum rotation is supposed to occur in first 1 hour. That's called golden hour. So better to see the patient after 1 hour and ask the patient to lie down supine. I don't know to what extent it helps, but this is what has been advised. And as per the post-op management is as per any other cataract removal. And then, of course, we have to keep in mind the patient's perspective. Patient has come to us for good vision, visual recovery. And then, in my opinion, toric IOL practice is far more forgiving. And a well-planned toric IOL surgery should give a satisfactory result to both the surgeon and the patient, and maybe near perfect, picture perfect vision. Thank you very much for your patient listening.
Yeah. So thanks a lot, Satya, for your very informative presentation. As Dr. Anand takes stage to get your slides are okay worked out? Yeah. So Anand will be talking to us on recent developments in post-refractive surgery situations. Any questions for Satyamurthy? See, for example, pterygium patients after pterygium surgery, there's so much of irregular astigmatism. I have never thought about doing a multifocal lenses for those situations. But so that is, I think, one thing that is my experience. I thought I'd like to share with you.
Correct, sir. No, but it's not an absolute contraindication.
Yeah,
the only
absolutely.
thing
Yeah.
you
But
have to
generally,
wait for the stability
generally.
of the cornea, topographic
Yeah.
stability, probably.
So one more question to you, sir, Sadhmu sir. You told that compare the keratometry with different instruments, but different instruments will give different readings. For example, AutoRef measures at 3 to 3.5 mm. If you take the IOL Master 700, it measures 1.5, 2.5, and 3.5, and takes the average of that. So you cannot compare the keratometry. If you take for example, the Varion, it takes central 1.2. So basically what I personally feel is, SIM-K, what we take from topography, is for just the axis alignment, for axis reason, not for the keratometry purpose.
No, that's fine. No, I told you in the very beginning that IOL power calculation includes keratometry also. Whatever you are used to, probably that's the best way. It may be not necessarily a topography thing, it can be autokeratometry also. Whatever that works very well in your practice, yes.
So thanks a lot. I think now we'll move on to, I think there's one question, there's the last question, and then we'll move on to Anand.
With respect to the golden hour you mentioned, what are the reasons for the IOL rotation during that hour, sir?
Pardon me, sir. Come again.
With respect to the golden hour that you mentioned, what are the reasons for the IOL rotation in that hour?
No, there are a lot of factors, modifiable as well as non-modifiable. Few things like visco, if you don't remove properly underneath the lens, or maybe you overhydrate, these are modifiable, and then you make a large rhexis, which again precludes, and then the haptic design also matters. But non-modifiable things like a large capsular bag, a high myope, select the large anti-segment, maybe something which you really can't help. But I mean, this is what most of the cases, 95% of the cases, it will not rotate.
Yeah.
Thank you, sir.
So thanks a lot, Satya. Before Anand starts his talk, Dr. Doug, would you like to add any comments to whatever has been discussed so far? Would you like to add any comments? Any take-home message in this topic? No? Okay.
The comment about topography is a very interesting one, and it's very relevant. You have to know each of the topographers, they have a different definition sometimes of SIM-K. For example, in the Galilei, the SIM-K is actually the average over the central 3 millimeters. So each one is different, and I tend to agree that we rely on our two biometers. We do two measurements, LensStar and IOL Master 700, and we used those numbers for determining the magnitude of the astigmatism. And we actually even include the refraction of the patient, because sometimes that gives you a clue about what the patient really sees with their astigmatism. So there's a lot of art and not as much science as we still would like in that area.
Thanks a lot. Yeah, Dr. Ritu.
As far as the topography goes, what about the EKR, like the holiday report? Should that be more accurate than, I mean, SIMK is not something that you would use for your IOL power calculations.
Yeah, what would be your response, Dr. Dog?
The EKR, the holiday report that you get on the Pentacam. So those K readings would be more accurate?
Well, I'm not actually a big fan of the Pentacam for my IOL calculations. I still think that the biometers are better, and the reason for that is that the biometers give you, they're measuring the cornea by reflection, and reflection is more precise for measuring corneal power. I think the EKR from the Pentacam is fine, and I think it's a useful thing to use in addition to biometry. But I would probably, if I have biometry, I love the slide that he showed with the good Myers. If you have good Myers with biometry, particularly if you repeat it and you get that accuracy, to me that's the gold standard.
Thanks a lot. So Anand, over to you.
Thank you, and it's a privilege to speak in front of an audience which does include Dr. Kaur. I've been asked to speak on advances in IOL power calculation in post-refractive surgery patients. I guess the simple answer will be get an optical biometer, and that would be the end of my presentation. But to go deeper, I guess I would like to express my financial disclosure in Zeiss, Tommy Nidek, and the Lenstar, for which I have none, but it would be nice to have some. I guess getting accurate IOL power is like achieving nirvana, especially in these difficult cases. And since we have post-Mahakumbh, it's a good idea to try and continue that feeling. Perfect cataract surgery is no longer utopian. Getting 6x6 vision in majority of the patients actually works quite well. Our promises are, we promise sutureless patients, sutureless surgery, painless surgery, less post-op recovery time, but we also have to make sure we want more, not less, for our own services. I'll start with one patient, 58-year-old lady in the business of government contracts, diagnosed to have cataract at another hospital, wants to read the Bible without glasses. Her children are doctors. Son is a clinical trial specialist. He's done intensive research on the different types of IOLs and me. He's read my papers published, has a discussion on my PCR rates, number of premium IOL surgeries done, and son discusses the average post-op results, including the confidence intervals. The daughter wants to observe surgery, and she does come in for surgery. The patient's pre-op preparation included antibiotics and NSAIDs, and my pre-operative preparation included prayers to Vishnu, Shiva, and Jesus. And luckily for them and me, the surgery went off perfectly. Post-operatively, in a post-RK patient, we were lucky with good vision post-surgery in this patient with trifocals. And at the end of the day, the management was happy with the income, and I was happy with the outcome. Getting accurate power post-surgery, especially in these set of specific conditions like post-refractive surgery, keratoconus, ectasia, post-RK and post-keratoplasty are important, and it's important to know how well we really do in these situations. Getting good results in normal eyes, probably in more than now 80 to 90% of majority of patients. Some of the formulas even give us 92% in 0.5. But post-refractive surgery, keratoconus, and these specific set of patients do give some challenges. We do know about smile and lenticle extraction, which is probably now fairly commonly performed. You got smile and LASIK PRK, wherein the corneal surface is changed. But in RK, there is an intentional wound weakening which does alter both the anterior and posterior surface, which is slightly different from LASIK or a PRK where predominantly the anterior surface is altered. And this is important because we do know that the radial incisions flatten the central cornea. The central flattening with peripheral steepening causes the irregular astigmatism, fairly common. You do still see those post-RK patients, and the impact is basically significant K errors, which sometimes requires a historical data approach. Now, what are the fundamental challenges? You got an unpredictable the final lens position. You got unreliable K readings, which gives false corneal measurements. So in myopia, you tend to get wrong readings, in hyperopia as well. You got an altered corneal shape, and you are missing some historical data, which does affect the final outcome. The refractive surgery challenge is basically a standard IOL power calculation. You need to have predictable corneal curvature, you got to have regular aspheric shape, and it assumes a standard relationship between anterior and posterior curvature. While post-refractive, all this actually changes. The traditional K readings then becomes unreliable, and the effective lens position predictions also become challenging. There are, of course, multiple methods, historical and no history method. I would not touch upon the historical method because that's less commonly used, but we do still use the Barrett's true K, and there are, of course, some other formulas which can be helped to confirm your final K. Now, the double K method, which looks at preoperative and the postoperative K, and then this is put into a Vergen's formula, and there is a formula adjustment which helps to improve the accuracy. When you look at IOL formula generations, we are now predominantly in the 4th and the 5th generation, and I know there are audience among us who have used the 1st and the 3rd as well, but now the level of accuracy, even with the 4th and 5th in this specific group of post-refractive, is still not that perfect. The important parameter is the direct corneal measurement. You have multiple methods, Scheimpflug, which was mentioned. You have OCT-based methods, ray tracing, probably the new kid on the block, and you have true net power, which some machines actually gives, which accounts both for the anterior and the posterior surfaces. When you look at recent publications, and this is one publication I could find in Indian eyes, the predictability of the ASCRS online calculation versus the Barrett's true K, the predictability was maximum actually for the Barrett's true K and the Sharmas. So I think if you want to take one formula, at least in Indian eyes, a true K would be a good starting point. Now, the other important point is this is a meta-analysis, and wherein they looked at the accuracy for 0.5 and 1 diopter. And I feel if you have a normal eye, 0.5 probably makes sense. As eye surgeons, I feel we need to be kind to ourselves and accept that +1, -1 is a better range for these challenging eyes. And in majority of these specific formulas, it can vary between about 80% for majority of the present formulas that are being used. The meta-analysis does show that for a set of normal eyes, majority of them do better than 80%. But there is a difference between myopic and hyperopic corrections. Myopic accuracy is a lot better compared to hyperopic, and that's probably the way that the laser is ablated. When you look at optical biometer comparison, is there a difference? Well, most of them, at least in terms of axial length measurement, very, very close. In terms of the corneal, the spherical difference, not a lot. So any machine that you invest in these high-end machines would probably not really make a bigger difference, and I think all of them would be fine. And I have access to the Tommy and the IOL Master. I feel both of them actually do quite well. But there are some specific factors in the IOL Master, Lenstar, and the Anterion. Anterion Argos has come in a lot more recently and tends to give better epithelial thickness mapping and has ray tracing capabilities, which probably gives us a slight edge. In terms of foveal fixation, I know the IOL Master is probably the gold standard, the first one that actually started this revolution of biometry. In standard eyes, I think all of them are very, very good. Most of them actually do quite well. When you looked at formula comparisons for post-refractive patients, within about, most of them cross 70% for about 0.5. So I think in terms of the formula, if you have to measure it, the K measurement along with the axial length measurement would be critical. There are some strengths and limitations for a lot of them. The Paris-Druck is excellent for all refractive surgery types, but it is limited in extreme axial lengths. The Kane formula has some AI input, requires an internet cushion, and probably slightly less published than what has already been done. The Hages-Elb, probably good for myopic, less accurate for hyperopic and RK cases. Intraoperative aberrometry, probably the best available if you can get that, if you have access to the technology. It allows a final adjustment for lens rotation and exchange if needed. There are, of course, emerging technologies which are AI enhanced, but when we look the word artificial intelligence, I think the artificial part is the machine, the intelligence part is still going to be the surgeon. There are some cloud-based calculators, there is some high-resolution OCT, and there is some talk of personal lens design like the LAL IOLs, which does help. When you have a problem flowchart, which we use, you have to have a patient assessment, you collect the data, you look at the formula selection, you try and compare across multiple formulas, and if you have access multiple machines, and then you select the lens. You need to always give a 1 in 10 chance that you may not be in the perfect range. So key takeaways, you have multiple formulas, a good idea to cross-validate across 2 methods. You need to use modern technology. At present, probably OCT-based biometry is the most advanced, and you need to manage patient expectations. Thank you so much, Arup, for allowing me to be a part of the session.
Thanks a lot. You brought up a lot of interesting points. We'll be coming to that, and then I would announce the next speaker. He is the keynote speaker, Dr. Dow Koch. I would request you to be there on the podium.
Questions can we ask later on?
Yeah, maybe after his talk, perhaps he would have addressed many of the issues, and then we'll take the questions together. Now, as regards Dr. Koch, he does not require any introduction. All of us who do IOL power calculation have heard about him. But anyway, just for the formality's sake, Dr. Koch is a professor of ophthalmology and the Alan Mosbacher and Law Chair in Ophthalmology at the Cullen Eye Institute, Baylor College of Medicine. He has taught over 300 residents and fellows and has over 300 peer-reviewed articles and given 41 named lectures, including the Jackson Memorial, Kellman, Binkhorst, Baraker, and Lance lectures at the American Academy. And then he also has given the Charles Kellman Innovative Lecture at the ACRS, the Binkhorst Medal Lecture at the ACRS, and the Arthur Lim Lecture at the APCRS. He is the editor emeritus of JCRS and past president of the American Ophthalmological Society, ASCRS, and international member and the past president of IIIC, International Intraocular Implant Club. So with these words of introduction, over to you, Dr. Dow. Can we have his slides on the screen?
They're
Oh, yeah.
good.
Yeah.
Thank you, Roop. What a pleasure it is to be here. You have heard several excellent talks. I could almost just sit down because everybody did such a great job covering the topics, but I'll go ahead and talk a little bit about. It's interesting to think of the history. The first IOL was 1949 when Ridley implanted it, and that patient came out -20. And so he had to do an IOL exchange. So that was also the first IOL exchange. The first Virgin's formula was 1967, Fyodorov. Then the first regression, 1990, with Retzlaff, Sanders, and Kraft, SRK. And then the first ray tracing formula by Rolf Preusner in 2002. Well, you've already heard this paper discussed that with Adi Abalafia. Most of us are probably hitting about 80% within a half diopter of target. The best one is this one paper that showed that you could be 92%. We use Veracity, which is a system from Zeiss that amalgamates all of our data. And I took a snapshot at one day, and I found that I was 91% within a half diopter. I took a snapshot of my data about 3 months later, and guess what? I was 85%. So I'm afraid to take another snapshot of my data. I may be at 60%. We'll see. But it's interesting to have something like this that can actually continuously evaluate your data. So where are we? I think if we're really good, in most patients, we're about 90%, which, as mentioned, I tell patients you've got a 1 in 10 chance. You're going to be off by more than you want. But is it even routinely achievable? Well, we calculate power in a number of ways. The classic formula is the Virgin's formula, where the power is you put in is calculated using the predicted refraction, the axial length, the average K, and the ELP. And the ELP, of course, is one of the big problems because every formula has its own internal formula for calculating effective lens position using various variables. So how do we measure? What do we measure? We measure anterior corneal curvature, axial length, anterior chamber depth, lens thickness, corneal diameter, and some programs use posterior corneal curvature as well. But those top 5 are the ones that the newest formulas use routinely. Corneal thickness is another. And some formulas use some combination of these: refraction, age, gender, ethnicity, the ratio of the curvature of the posterior cornea to the anterior cornea, and corneal asphericity. So the sources of error in our world today are ELP calculation, cornea anterior, cornea posterior, and I still think we have some questions about the posterior cornea, and refraction, because we need accurate refractions to report our data. And even axial length measurement is not infallible, and I think that's why, for me, I always like to see 2 different axial length measurements in my patients to make sure that there's good consistency, because you can be off if the patient wasn't fixating correctly, for example. And we use validation criteria for axial length. If the eyes, right or left, are within 0.2 millimeters, I feel better. The standard deviation for axial length should be less than 0.02 millimeters. And the range for phakic anterior chamber depth, 2.5 to 4.5, and lens thickness, 4.0 to 5.5. I operated on a lady last week whose lens thickness was 5.9. I felt like I was in the operating room for 2 hours trying to get that lens out of the eye. So we have a huge number of formulas that keep being developed, and all of them primarily are designed to overcome this problem. How do you calculate the effective lens position? And I wrote an editorial in 2018 in the JCRS. I think it's time to really stop classifying formulas by generation. Instead, look at them by the type. Those that use geometric optics, and they differ primarily by the number of variables that are used for calculating the ELP, ray tracing formulas, purely artificial intelligence formulas such as the Hill RBF3, and a series of formulas that combine all of these different parameters, some geometric optics, maybe some ray tracing, some artificial intelligence. But the truth of the matter is, every one of our formulas uses some form of at least big data, looking at results, and they use those results to refine the formulas for the ELP that are calculated. And so there's a kind of a smearing or a combination. These distinctions are becoming less and less valid. Ideally, ray tracing should give us the best results because it incorporates all of the aberrations from the front of the cornea, from the back of the cornea, from the lens implant. But the limitation that ray tracing faces is the same one every one of these formulas traces. It doesn't provide a solution to calculating ELP that is unique from other formulas. So it really has not turned out to be any better than our other formulas. And it's probably going to have a more useful role in eyes with irregular corneas, but the data to date don't suggest that that's come to pass. So what do we do about predicting the ELP? Can we be more accurate? People have used OCT either preoperatively or intraoperatively to try to look at the lens equator and use that and some anatomical features of the lens capsule itself to improve the ELP prediction. And some of these studies have shown that the ELP prediction is a little bit better, but none of them in those studies have translated actually to more accurate IOL calculations. And the bad news is, with the ELP shifts postoperatively, and I think it's unpredictable. How many of you have seen a patient who's 20/20 on day 1 post-op and they come back at 3 weeks or 4 weeks and they're minus 75 or -1 and furious? I mean, we all see those. And and there was a paper by Nino Hernschall where he showed that 17.6% of eyes, the ACD shifted a millimeter or more from 1 hour to 2 months. Now that's discouraging. So is there anything we can do about the ELP issue? Well, I think that it will probably get a little bit better with some advanced imaging. If ultrasound, for example, could become easier and more facile, but it's still a problem. And the biggest problem with ELP is in short eyes. So short eyes, I think, are, in my practice, one of the biggest challenges because it's they typically have a shallow anterior chamber, but they get a short axial length. The cornea, these short eyes, can be flat or steep, depending on the type of short eye, what the anterior segment looks like. The anterior segment can be small or normal. The lens is usually thick. The sclera is thickened. And there's a lot of variation among eyes. So the formulas for short eyes are routinely challenged. And this is a wonderful slide from Thomas Olson, inventor of the Olson ray tracing formula, where as you can see, as you move to the left, as the shorter the axial length, the greater the error. 1 millimeter error in ELP results in errors in the accuracy of 2 diopters or more. And here's a good example. This is my patient, hyperope, axial length 21.4, shallow anterior chamber 2.39, fairly thick lens, corneal diameter quite normal. So I used that Barrett, Holiday 2, and the Hill RBF 3. That's what they calculated, and the outcome was -2. So the prediction error was around 2 diopters, and the postoperative anterior chamber depth was 3.6, which is fairly shallow for a pseudophakic eye. So I exchanged it. How do you calculate the power when you're doing an IOL exchange? Well, the Barrett formula is very good. And there's also what we call the subtraction method, where you simply take the myopic error and you multiply by 1.2, very simple rule of thumb, and both the Barrett and the subtraction method said I should put in a 25.5, which I did, and she ended up plano plus a half at 175. Very happy. What do I do for the second eye? Well, the second eye had similar anatomy as the first eye. And the old teaching is that if you have an error in one eye, you should adjust the other eye by half of that amount. That's based on a series of papers, one of them Thomas Olson. So that's what I did. I targeted around +1 for the other eye, thinking that she might end up around plano, and she ended up -1.6 spherical equivalent. And so luckily she loves her monovision, but that just goes to show with these eyes, with this unusual anatomy, and they're very similar to each other, we should adjust the IOL power 1-to-1. That would have meant I would have had to aim for +2 in her other eye, which takes a lot of courage to do, but that would have given her a more accurate calculation. We did a paper recently looking at segmented axial length, artificial intelligence approaches to short eyes. We looked at the best formulas, 155 single eyes, 123 paired eyes, axial lengths ranging not that short, 19.77 to 22, 3 IOL models, and we looked at 15 formulas. We used the newest statistics, and we looked at the top ones. This is the Zeiss AI IOL calculator, which is available from Zeiss, but it's only available on their program Veracity. And what it does is it first takes 500,000 eyes and then ray tracing using real parameters. It then looks at the post-op prediction with those and compares it to those other calculations, and the formulas are constantly refined by post-operative data. And if we look at the percentage of eyes in these short eyes again, within a half diopter, the Zeiss AI was 73%, but every other one, including the Hill RBF, the Barrett, and so on, were under 70% within a half diopter. So if you got a short eye patient, you have to tell them they've got probably a 4 out of 10 or a 3 out of 10 chance of not being accurate. So let's go back to my patient. Did any of these formulas work well in my patient? And the answer is no, they were all off, including the Zeiss AI. Actually, the Cook formula was the most accurate there. In nanophthalmos is even more challenging. The formulas can have errors by 5 diopters or more, and we have a challenge because in the US, we have the highest power IOL we have is 40. You folks from India and internationally can get other special lenses. One was from Human Optics and a company from Italy, Soleco, up to 72 diopters. But remember, these eyes can be really inaccurate. And piggyback IOLs, I actually learned this from colleagues here in India. You have access to these wonderful add-on lenses that I think they're this is the one time in a short eye one could probably use a piggyback IOL, but I'd like to hear people's experience with that. Long eyes, we're doing better. The first real breakthrough was our Wang-Koch modification, where we took the axial length and we put it through a formula, and we just looked at analysis of 1,600 eyes, and we had 93% with a half diopter. So we do very well with long eyes, and you also have access to great formulas now with the Hill RBF, the Barrett, the Kane, and the Olsen. And we're doing better with them because the power of the IOL is low, and so the ELP has much less impact about outcome. Well, what about the cornea? You've heard some great talks this morning about the cornea. And the cornea is the largest source of error over which we have at least some control as surgeons, as you've heard this morning. It affects the accuracy of our calculations, which kind of IOL we should be using for our patients, and what we can predict the postoperative vision to be. Here's an example of a patient of mine. These are the readings on the preoperative visit, the K4334, astigmatism 2.05 at 174. IOL Master didn't give me any K readings for this patient. And I looked at the Myers, and there was a missing data point down there on the lower left. There's one of the Myers did not reflect. So it turns out I had measured this patient 3 months previously with a Galilei, and the K readings were 44.6 compared to the 4334 with a Lenstar, and the astigmatism was 1/10 of a diopter compared to 2 diopters with a Lenstar. And I looked at the Lenstar, and you can see there are distorted Myers in exactly the same area that I had with the IOL Master. Well, what I did, of course, is treated the dry eye, and actually within a week everything was uniform, and on post-op week 3 we had good readings, 20/20 J2 with an EDOF. So the lessons are you need more than one measurement, you've got to verify the quality of your data, and we've seen a good example of that. These Myers are very easy to see. The slides earlier that showed the Myers, that's more subtle, so you have to look very carefully. And you can use mathematics, the standard deviation that Warren Hill has taught us. If the standard deviation for the power is over 0.3 or for degrees over 3.5, you have to really be wary. In my clinic, we get placido topography and tomography on every new patient and every pre-op patient. That's the Galilei. And I like the Galilei because it has Myers, it has the placido Myers, and that gives me a good sense of the raw data. And unfortunately, with the Pentacam, you don't get those data. You don't see the image, and you don't get a good sense of the surface quality with the Pentacam. Biometry, I use 2 devices, and so I have a total of at least 3 measurements in my patients. And 2 weeks prior to, you've heard this again discussed this morning, every one of my patients is instructed to use preservative-free artificial tears, warm compresses, and lid scrubs for 2 weeks prior to IOL calculations. And we actually have a little counter where they can buy them as they go out the door, so they have them in their hand and take them home. So we heard a great talk about the post-LASIK eye. The interesting thing about the post-LASIK eye, if you think about it, is I mentioned the 3 sources of error. Well, those are the things that are magnified in the post-LASIK eye. The ELP, because the formulas use corneal power to calculate ELP, and it's been, of course, corneal power has changed. The cornea, the greater variability of the anterior cornea, we have this problem that when you measure the anterior cornea, it doesn't accurately reflect the posterior cornea in the post-LASIK eye, and refraction has soft endpoints. If you look at the series of all the papers that are out there, one study showed 85% with a half diopter of target, but every other study for myopic LASIK is less than 73%. And as you've heard, hyperopic LASIK patients can be even more challenging. One study showed 73%, but our results in a paper we published was 57%. Very disappointing. We thought that once we started measuring the posterior cornea and took that source of error out of our calculations, that we would become more accurate, and it really hasn't given us that much benefit. We just published a study on 85 eyes, and you can see the formulas we used, all the newest formulas, EVO, Hover QST, Pearl DGS, Holiday 1 and 2, and of course the Barrett. And what we found is only the Barrett was actually 73% within a half diopter of target, and every other formula was less than 70%, and just matches what you heard earlier today. Some of these formulas actually were off by more than a diopter, so you really have to warn your patients about this. Post-RK is even worse. I tell these patients, these are the most inaccurate eyes. And why is that? It's because when you measure the posterior, the RK cornea, you can measure the anterior cornea, and of course there's a lot of variability, but the RK, radial keratotomy, really affects the posterior cornea in a very unpredictable way as well. And so most studies show accuracy of less than 70%. One study showed 76%, but much better than our experience. And so we still like, in these things, to look at the Barrett True K, the average of the Ascaris calculator values, and I think that some of these newer formulas such as EVO, Pearl DGS, and so on are going to be really good as they get refined. So I'm a real fan of postoperative adjustment. And this is the RX site. You've heard about it. I don't know that you have access to it yet in India. It really is precise, but boy, it's expensive and it takes a lot of time. But of course, what it does, it has polymers or macromers in there that are not polymerized, and you can then treat them with light postoperatively to make these adjustments. And you can adjust up to about 2 diopters of sphere, up to 3 diopters of cylinder, and you can do up to 3 adjustments, and then you have to do 2 lock-in treatments to remove any remaining unpolymerized macromers. We start the treatments about 4 weeks post-op in our post-LASIK eyes. In an RK eyes, we wait 8 weeks to make sure they've stabilized, and it takes a long process. It's a long process for these eyes. And if you look at our accuracy, you can see on the right, in normal eyes, we were 96% within a half diopter. In LASIK eyes, 93% within a half diopter. In RK eyes, 84% within a half diopter. So these are certainly far better than anything that we can get with our standard IOL calculations, but it's a lot of time and a lot of effort. What about keratoconus? Well, we published a paper on this, looked at a variety of IOLs, we looked and included the Kane keratoconus and the Barrett keratoconus. And if the K readings were less than 50, we were getting about 70% within a half diopter target. If they're over 50, less than 20%. So there seems to be kind of around 49, 50, a big change. And of course, those are the corneas that have a lot more irregularity in their topography. And these are the best formulas in our study. There was discussion about statistical methods. We, with Jack Holliday, published a paper that showed that when you're doing IOL calculation analysis, the data are not normally distributed. You need contemporary statistics, and the standard deviation is the primary metric for formula comparison, and you can use this statistics even if the data are normally distributed, so you don't have to worry about that. This is all the information. You can read that about that in JCRS. And we also have now access to this wonderful website from Adi Abalafia called ITEMIS, and that also incorporates the concepts of the data not being normally distributed, and it's very user-friendly, and it's a great option. So, can we do better, or is 90% within a half diopter really is truly our ceiling? One other cause of error is these are kind of crazy numbers if you look at them. If you look at the manufacturing accuracy that ISO requires, for example, if you go from 15 to 25, the tolerance is plus or minus 0.4 diopters. Now, we know the manufacturers do better than that, but they're not held to very stringent criteria, and those numbers are pretty dismaying. So in conclusion, we're doing better, but we're really approaching a ceiling for accuracy in our calculations. And I think postoperative adjustment's going to come along, either something like RX site, or maybe this concept of refractive index shaping that is where you can actually take an IOL in the eye and adjust the power using a femtosecond laser. So it's an interesting time. We have a lot to do. And I think one other thing I'll just say is I think the future for all of us is going to be surgical planning software. And there are a number of them out there. Veracity, iTelligence is from Bausch & Lomb, the Cassini planner, and Alcon will be coming out with its planner. And here's an example of how you can use it in your practice. This is a patient of mine, wanted great distance vision, no glare, but some intermediate vision as well. So this is the left eye of the eye for intermediate. And there are the axial length data. You can see them, it just presented right to you. You can see the similarity in axial length. And you can see that the refraction, the K readings show astigmatism of around 0.3, 0.4 diopters at 30 degrees. And you kind of look at that and say, I don't really need to use a toric in this guy. He doesn't need it. And that's what the integrated K from Barrett is done. And then if we put a monofocal IOL in, the predicted refraction is, look at that, 0.68 at 10 degrees. So that would leave him against the rule, and he's 68. That's going to keep going against the rule. So let's see what it looks like if you put a toric in him. And if you put a one diopter toric lens in him, now the predicted refraction is 0.3 diopters at 100. So that's what I did. I put a toric in, and I aimed for intermediate, and he's 20/20 J2, and he has a half diopter at 75, which will gradually decline over many years as it goes against the rule. So you can see how the software really facilitates working through these issues with your patient very easily. Best practices this year: get more than one corneal measurement, preferably 2 or 3. Verify the quality of your data, and we have to educate our patients that this is an imperfect science. And of course, have a strategy to manage postoperative refractive errors, particularly with our multifocal patients. And I really thank you for the honor of giving this talk.
Thank you so much, Doc, for your beautiful presentation. So I just have a question for you. Now in India, we have 2 swept source OCT-based optical biometric devices. One is the Argos, other one is IONmaster 700, which are really commonly used. Argos always gives the sum of the segment axial length. Now, is it okay to use that axial length in the standard formulas that we use, like Barrett Universal 2 or Barrett Toric? Because I think they are meant for the composite axial length, not the sum of the segments.
Right. You know, the Barrett formula and a lot of the other formulas have already kind of taken into account the segmentation in the way that they do their calculations. So with the Argos, my understanding is, we don't have an Argos, my understanding is you have to use a slightly different 8 constant in the Argos in order to account for the fact the axial lengths are segmented. I don't think probably you can use the same one in each, but I would wonder, is that your experience? Did you come up with different numbers?
No, that I don't use Argos either, so I don't have a personal experience. But what I've heard is Argos, they have evolved in Barrett formula, which actually takes into account the sum of the segment.
Yeah.
And that is supposed to be more accurate than when you use the composite axial length for the Barrett Universal 2 formula.
Yeah, you know, our paper on short eyes, we did the segmentation and optimized, and we didn't find that it made much difference, because again, the formulas of, if you look at something like the Barrett formula, it's got hundreds of lines of code where all this stuff is folded in. You know, our axial length modification, all that stuff is already in the Barrett. And he's done a great job of kind of bringing whatever is available in. And so when you go to a new biometer, you know, it's going to take some time to kind of sort that out, probably. It would be my guess.
Any questions for Dr. Dow?
So wonderful
one
session.
question, yeah.
Yeah. So what would be your recommendation for calculating IOL power post press beyond LASIK? And it's a slightly hyperopic eye, or what kind of formula could be? Press beyond LASIK.
What, for what kind of patient?
Post press beyond LASIK. Press beyond, the blended laser vision correction.
Presbyon, the ablation profile for Presbyon. Well, that's a version of a hyperopic LASIK, right? So yes. I guess you would have to use your hyperopic LASIK formulas, you know. But like sometimes I know particularly with the Zeiss laser that does Presbyon, people are treating very high amounts of hyperopia, and the greater the hyperopic treatment, the more error you're going to have in your postoperative IOL calculations. So. Like everyone, I would say, first of all, thinking about the IOL, look at the corneal asphericity. After hyperopic LASIK, actually most corneas have about 0 asphericity, but for something like that, they're probably going to have negative asphericity, so you might want to use a lens that has 0 asphericity. But I would be very prepared to have to do an IOL exchange. Do your hyperopic LASIK calculation and tell the patient, you know, you've got maybe a 1 in 10 chance of needing an IOL exchange to get the most accuracy.
Which IOL would you prefer?
Well, which IOL?
Primary, the first one.
Well, I don't know what you have available to you here. We would use the Bausch & Lomb Invista model, which has zero asphericity. There are other IOL companies that make IOLs with zero asphericity. I just don't know what you have available here.
We have Invista.
Yeah. We have 3 more presentations to go. Maybe last comment from Anand.
I was just curious because when we look at, we've been using the Bausch & Lomb, the lens that you mentioned, Invista, as a option for myopic LASIK. But my query is always about when we are looking at sphericity and we are looking at spherical aberrations, the measurements are in microns. And if you're even off by about 0.4, 0.5 diopters, the spherical aberrations have little value. What is your comment on that?
Yeah, I mean, that's right. The most important thing is getting the power right. And spherical aberration only becomes, spherical aberration may become relevant if there's a lot of asphericity. Well, let's put it this way. In myopic LASIK patients, of course, there's going to be positive spherical aberration. So you can use a zero spherical aberration IOL or one with negative asphericity in order to try to improve that. And wherever that refractive error is, you would think that the sharpness of the vision might be a little bit better. But in terms of uncorrected acuity, yeah, the asphericity of the IOL is minimal effect. Very good point compared to being off in power.
Thanks a lot, Rao, for your wonderful presentation and for the questions. So can I have my laptop on the screen? Yeah. So there are a couple of challenging situations in IOL power calculations, and some of these have already been discussed in the course of these presentations, and Subin is going to talk about the extremes of the eyes. One challenging situation is the post-vitrectomy cataract. There are actually 4 hurdles to overcome in these situations. Axial length determination can be really difficult, particularly with a posterior segment silicone oil field. And then with a plethora of intraocular lens formulas, newer formulas coming up, so which formulas do better in these eyes. And once that is sorted out, and then what exactly is the IOL power we're going to use? Because we know that if silicone oil is kept in the is in the posterior segment, there's a hyperopic shift that happens. And if the silicone oil retention is planned for a long period of time, then how do we modify the IOL power that is implanted? And of course, you have to use an appropriate intraocular lens. We don't use it, and the silicone lenses are no longer available. So hydrophobic acrylic single-piece lenses are the best lenses. So, the most important cause of error in IOL power calculation in these situations is basically the difficulties in axial length measurement. Error in axial length measurement can arise because of overestimation of axial length in silicone oil field eyes if you're using ultrasound biometry. Underestimation of axial length in eyes with macular edema when axial length is measured again using ultrasonic biometry, and underestimation of the length when ultrasonic biometry is used in patients with rhegmatogenous retinal detachment. So it would be best to do a prophylactic step. So whenever we have a patient who is scheduled for vitrectomy, we invariably perform an optical biometry if that is possible. And if it is not possible, then we do an ultrasonic biometry. And the results are archived in the hospital, and a copy is also handed over to the patient for safekeeping. Now, there may be situations where a patient has been operated elsewhere, there's silicone oil field, and we don't have the axial length data. So I would perform an optical biometry in the silicone oil mode and get my values. But optical biometry may not work in certain situations where, if the patient has fixation issues, if there's an advanced or total cataract or thick posterior subcapsular cataract, then you have to perform an A-scan biometry. And here the real problem starts. Because we all know that in ultrasound is attenuated by the silicone oil in the posterior segment. You get poor retinal echoes. There are reduplication of echoes, as you see here in this slide. So, and whatever axial length you get, that is an apparent, and that has to be converted into a true axial length. So this is actually a slide from Warren Hill. So here, this patient, he has used a velocity of 1532 for the entire measurement, and then the axial length that has been calculated is 36.28. And then when the correction factors have been applied, then ultimately it comes down to 25.69 millimeter, and which tallies quite well with optical biometry results. So there is a way of getting around these situations. There are certain situations where you have, silicon oil half filling the posterior segment, and you cannot do an ultrasonic biometry in those patients. So it is when the patients are supine. So it is good idea to keep the patient sitting and then perform a ultrasonic biometry. And in certain situations, nothing seems to be working. So, what has been described in the literature is, you can do a CT scan or MRI or go by the axial length of the fellow eye, use a standard power, which I really won't recommend, or you can get the investigations done after the silicon oil removal. Say, for example, after the silicon oil removal, intraoperative biometry can be done after pressurizing the globe with an infusion, and the results seem to have been pretty accurate. I don't have any personal experiences, but that is one of the things, one of the options. Second option would be to, after the cataract surgery, perform an intraoperative retinoscopy, and then use these formulas to calculate the intraocular lens power that is to be used for these patients. Now, the next thing is how do we select the IOL power? If you have silicon oil in the posterior segment and you don't plan to remove the silicon oil in the near future, because silicon oil has a different refractive index, so it always results in a hyperic refractive error, and this is actually accentuated depending on the lens shape factor. So if you have more carved posterior surface of the lens, the post-op error will be more, and it will be less if you have a plano posterior convex lens, which I think is not available in the foldable lens format today, and meniscus lens would be the best. So actually, if you see the Warren Hill site, so he suggests the use of a lens which is 3 to 3.5 diopter more if you get to implant a plano convex lens with a plano surface facing posteriorly. And if it is a biconvex IOL, then basic rule of thumb is for lenses more than 20 diopters, add 8 diopters. For lenses between 15 and 20 diopters, you add 7 diopters, and add 6 diopters for lenses between 10 and 15 diopters. And these are all the situations where the silicon oil is retained in the posterior segment after the cataract surgery. And these results have been corroborated by a couple of studies as I've shown here. Now, as regards the newer formulas, and which is most ideal. So there are different scenarios when you do cataract surgery in a vitrectomized eye, or cataract surgery in a vitrectomized eye with silicon oil retention, and then patients switch where you do cataract combined phaco with vitrectomy and membrane peeling, etc. So what are the new formulas? So there are various studies which compared the new generation formulas with the traditional formulas. New generation formulas excluded were Hill, RBF, Olsen, and Holliday in these particular studies, and it was seen that for the new generation formulas did extremely well for all these patients where cataract surgery is performed in vitrectomized eyes. And traditional formulas, as Dr. Dowd had already mentioned, with Bangkok adjustment had also done extremely well. Now, when you're doing a combined phaco with silicon oil removal, again, the EVO formula appeared to do best for these kind of situations. And when we do a membrane peeling, vitrectomy membrane peeling and for epiretinal membrane, then Kane formula seemed to have given the best result according to this particular study. If you have a patient with a macular edema and somehow optical biometry has not been possible, and you have done a ultrasonic biometry, so it is been our experience that you get a postoperative residual myopia in these patients. So it is a good idea to reduce the IOL power by maybe about 0.5 diopter. So friends, in conclusion, there are intrinsic challenges to full visual recovery in eyes with posterior segment pathologies. In spite of that, you should make all efforts to optimize the visual outcomes by resorting to the latest technology techniques, the current concepts, and the newer formulas. So thank you very much for your attention, and I would request Suven to talk on extremes of eyes.
Can you just leave the mouse alone? Yeah, good morning, everybody. Thank you, Arup, for the kind invitation. And can you please leave the mouse? Yeah. There's an advantage of speaking after Dr. Koch, is that you really don't have to speak, because he's covered most of what I had to speak. The biggest disadvantage is you'll find how inadequate my talk is. So let's get on with our business. I'll try to stick to basics. I'm a little intimidated by these formulae. So, like Doug Cox said, that it is essential not only to implant an IOL, but to be accurate too. And no, I mean, we have to give credit where it's due for the implantation of the IOL, but then there were errors with Sir Harold Ridley and even Binkhorst. So, and it is also true that we need to attend meetings like this and get updated so that we use the most current practices in our day-to-day work. Now, the biggest difference between ultrasonic biometry and optical biometry is in terms of accuracy, where there is a lesser resolution in ultrasonic, and in the optical it's pretty close to, the measurements are 0.012 millimeters. Now, why is this a problem for us? Because if you look at the combinations that are available, there are 9 types of eyes, if so to say, if you see the anterior segment size and the axial length. So, and unfortunately, less than 75% fall within the normal of the axial length and the normal, anterior segment normals. So, this is something we've been through repeatedly through the morning, so I'll skip this part. Now, this is where the optimization worked, where in long eyes, the formulae at that point in time tended to select IOLs with insufficient power, leaving postoperative hyperopia. So, this optimization by Wang Kok significantly reduced the percentage of long eyes with the hyperopic outcome. So, these are now things of the past. Now, we have what is called static formulae and dynamic formulae. Static formulae are one which you actually don't change over a period of time, and if you actually do a fudge factor for the A constant, the entire formula shifts up and down, which really has no value. The AI-based formulae or the more current formulae adapt dynamically with time, and as you will see, the orange line is where it starts, and that's off by about a larger amount of variation in diopters, and as data gets added on, it comes closer to the blue line where you are within, as close to 0 as possible. This again is something which we've been through many times in the morning. So, this accuracy of intraocular lens calculation formula, by and large, Barrett Universal 2 has served the purpose for good purpose for a long period of time. Now, if you look at the prediction error in diopters versus intraocular lens power, again you will see that the Barrett formula does best, and then it's followed by Huygens and the other formulae. And if you look at the prediction error in diopters versus the axial length, again the Barrett did better than others. Now we come to the crux of the problem, short eyes, as Doug has told us that now there is something which we have to understand very clearly. A small axial length combined with a high power IOL can cause a large refractive surface even with a minimal shift in ELP. Now, ELP has been the biggest bugbear in the entire IOL calculation process, and if there is a small shift over here, this is a huge difference. And there is something which Doug also touched upon, but I don't know if most of you understood the significance of that particular slide. Tolerance of IOLs with a power of higher than 30 diopters is plus minus 1 diopter as per ISO standards, which means the manufacturer can get away by making a lens of 29 diopters or 31 diopters for what you choose as 30. So, you'll be off by 1 diopter clearly, and the manufacturer cannot be blamed for that. So, that is something which you have to keep in mind. Now, in short eyes, this is a meta-analysis. Again, this showed Barrett Universal 2. This is slightly older data, but then this is a good meta-analysis. Barrett Universal 2 served the purpose better than others among the formulae. And then the newer generation formulae, the Pearl DGS and the Oculix work better. Now, in long eye, there's a large vitreous component, and that contributes to errors over here. So, and if you look at, and there is another problem. See, in the long eyes, we have poor fixation, and we have a staphyloma, and you don't know where the macula is on the staphyloma, which part of the slope it is on, and that's where our inaccuracies come from. And if you look at figures, if the axial length is greater than 26 millimeter, a 1 millimeter increase in axial length led to an increase in absolute error by about just 0.1 diopters. Now, when the axial length increased to 33 millimeters or more, the error was about 1.1 diopters. So the axial length makes a lot of difference. Prevalence of posterior cephaloma by axial length, if it's 26.5 millimeters, it's just 1.4%. And when the axial length goes to 33.5 millimeters, it's almost 70%, more than 70% that have a cephaloma. So that's where the errors are going to happen. So in long eyes, what we have is the optical biometry assigns a single global index of refraction, and that's where the problem lies. So because of the greater amount of vitreous over here, so longer the eye, the greater the error. So, and also we need to remember that in high myopia, it need not necessarily be a long eye. It could be what we call index myopia, or like in ROP, you have high myopia which is primarily lenticular. In sticklers, you have high myopia which is axial. In Marfan's, you have a combination of both. In long eyes, again, in this meta-analysis, they found the Barrett Universal 2 was much better than others. And newer generation formulae again showed more accurate results. Now, in summary, the accuracy of the refractive power of the intraocular lens depends on the exactness of the IOL power calculation formulae. Now, accuracy depends on the axial length and corneal curvature primarily, but then ELP is a huge contributing factor, which is still an enigma. There is no consensus as yet in literature, and we have surprises every day with every formula. So a review of current literature, which is it's an evolving process, it's a dynamic process, and we need to evolve along with the formulae. So Barrett's Universal 2 or the True K are among the Vergence formulae which are working well now, and the KN are the Pearl DGS, and probably some Hill RBF are working good among the AI supported formulae. Thank you very much for your kind attention.
Thanks a lot, Suvin, and we now come to the last talk of the day, Dr. Nirupama. She is going to give us the take-home pearls and wrap up the session. Dr. Nirupama is an additional professor in JIPMER. She was the head of the department of ophthalmology there, and a very, very brilliant ophthalmologist. Over to you.
A very good morning. As we come to an end of this instruction course, so I would sum it all up and give a few take-home pearls. So to optimize the IOL power calculation and reach the target refraction, we have to keep three things in mind. One is to make the biometry measurements as accurate as possible using the latest tools and technologies. Second is to use the advanced generation formulae to calculate the IOL power. And third is to give due considerations to all the special situations like we discussed today, whether it's a toric IOL, post-refractive surgery eyes, post-vitreoretinal surgery eyes, or if it is extremes of axial length like long or short eyes. So the first and foremost, before doing the biometry, please check whether the ocular surface is good, rule out any dry eye status. If the patient is wearing any contact lens, it should be discontinued even before doing a keratometry. Measure the keratometry on a virgin cornea even before application of any eye drops or contact procedures. So always repeat the biometry on the same day with two different instruments or on two different or three different instances to make sure that the calculation is bang on the target. And we can also repeat with one or more formulae and interpret the values with caution. Always look at the raw data and check whether there is any asymmetry between the two eyes. So check for all these red flags when there are any variation from the normal range, and then recheck the measurements. So always consider what the patient wants, whether he wants emetropia for distance, intermediate or near, and depending on that we need to choose the type of IOL, and always counsel the patient also depending on what will be achieved. And look at your own results, and you can actually adjust the A constant, and that will shift the power prediction curve and optimize the IOL formula to work well across all ranges of IOL. So for toric IOLs, always use toric IOL when it's a stable, consistent and regular astigmatism, and avoid toric IOL when it is any irregular astigmatism. Always check the cylinder in the spectacle refraction, the optical biometer and topography, and see whether you're getting similar readings. And use the Barrett toric calculator So that comes with both predicted and measured posterior corneal astigmatism, and both actually are giving very good accurate results. And this posterior corneal astigmatism definitely has to be taken into account when calculating the IOL power for toric IOLs. Otherwise, for with the rule astigmatism, we'll end up with overcorrection, and for against the rule astigmatism, we'll end up with undercorrection. And always when we calculate the IOL power, the toricity which is on the cornea is different from the toricity which is in the IOL plane, and usually the toricity on the IOL plane is around 1.5 times greater than the corneal toricity. Always consider the age of the patient, because young patients usually have with the rule astigmatism and older patients have against the rule astigmatism. And if we are using consistent temporal clear corneal incisions, usually the surgically induced astigmatism is very minimal and close to zero, and it is the centroid value which is around 0.08 to 0.14. And always do a proper surgical technique and OVD washout at the end of the surgery. And if there is an error or there is a rotation of the toric IOL, we have the astigmatismfix.com or Barrett RX formula, which will help us to know how much to re-rotate the IOL. So looking at the advanced tools and techniques that are available for us, we have different biometers which are giving very accurate measurements, of which the swept source OCT based machines like the Zeiss IOL Master 700, the Argos by Alcon, the Tomy and Antirion by Heidelberg Engineering, they are the best and they are more popular, which are used nowadays. The advanced formulae, especially those which are hybrid, which use both virgins and the artificial intelligence incorporated, are giving excellent results. And the best part is we have online calculators which are available free, especially in the ASCRS or APACRS websites, which are accessible to everyone and can be used. And we also have the aberrometers, the pre-op wavefront aberrometers and intraoperative aberrometers, which actually help us to fine-tune and achieve more precision. And even in the IOL armamentarium, we have very good IOLs, and even for higher powers, we have customized power IOLs which are available. So these all actually help us to achieve a very good post-op refractive outcome. So in VR surgery eyes, Dr. Arup has covered. So silicone oil eye fields always tend to overestimate the axial length, and eyes with a macular edema or if there is a bullous retinal detachment where the retina is slightly forward, that tends to underestimate the axial length, especially if you are using a ultrasound biometer. So always opt for optical biometer, and for silicone oil filled eyes we can also use a correction factor or schedule the surgery after silicone oil removal, or as Dr. Arup has mentioned, always do the biometry even before doing the silicone oil installation in the eye. And for gas filled eyes, there could be a forward shift of the iris lens diaphragm, so we can actually aim for a target hyperopic refraction. And scleral buckling surgery, it tends to cause globe lengthening, and that can result in a myopic surprise. So these situations actually tend to give refractive surprises to us. For post-refractive surgery eyes, if it is post-radial keratotomy, there is both alteration in anterior and posterior curvature, whereas if it is post-laser vision correction procedures, there is only alteration in the anterior curvature and the optic zone. So the formula where the effective lens position is calculated using the corneal curvature actually tends to give erroneous results. And since we have the Barrett True K Universal 2 formula, which actually is the most accurate in post refractive surgery eyes. Same thing applies even for irregular corneas like keratoconus or post LASIK ectasia. And the use of true keratometry or the total keratometry using the swept source OC devices, where the anterior curvature, posterior curvature and the central corneal thickness together gives us the accurate K reading should be used. And we can also use the Scheimpflug devices as it was discussed, where the holiday EKR report we get a K reading. These give good outcomes in post-refractive surgery eyes. And for extremes of eyes, if it is a long eye, always there is an error because of posterior staphyloma, and there is actually a paraxial overestimation leading to a hyperopic refractive surface. So for the older formulae, we use the Bangkok modification, but now Barrett Universal 2 is giving the best results for long eyes. And short eyes, actually the estimation of effective lens position is the one which is erroneous, and small errors also are magnified because of the higher powered IOL. And we can use higher powered IOLs, like we saw even up to 40 diopter is available, but piggyback IOLs also are good options in short eyes because the spherical aberration seems to be less. With this, we end the instruction course. Thank you. Over to Dr. Aru.
Thanks a lot, Dr. Nirupama, for wonderfully summarizing the whole session. I think I just need to add one point. The ESA's website was so far lacking in any IOL software, IOL calculation software. 2 years back, they have added on to that. And for the spherical calculation, there are 7 new modern formulas that are available. So you just have to feed in the data only once, and then you get a printout with all the 7 formulas. So that makes it very handy. So I think this news needs to get across, so make life easier. Otherwise, you have to plug in to different formulas, get the printouts and compare. So with these words, I think we come to the end of the session. It was a wonderful session. Thank you, Ramesh, Anand, Satyamurthy, Suben, Nirupam, and of course the star of the show, Dr. Daug. You made our day. Thank you very much. Wait. Ramesh?